Good evening, everybody. I hope everybody's doing well. I'm hoping that the team are going to be adding you as we go. So we should see the participant numbers popping up, which we do in the corner, which is always one bit of the technology to get right. Thank you to everybody for joining us for our back to school webinar for teachers and SNAs, and perhaps hopefully some principals as well, depending on if the time suits and if the topic suits. I'm going to give you an advance apology, which is that we have a small sick child in this house. So if people hear some wailing in the background, I'm extending my considerable apologies. But as Ruth was just mentioning, it's actually a very timely and appropriate sickness in the house, because it's exactly the kind of illness that you're going to see happening at schools near you, and possibly in your homes as well this winter, as kids get chest infections and pick up bugs. But I'm apologizing in advance if there's any interference on that zone. So just first of all, to say thank you to Trudell Medical, who have provided us with some funding and support for us to run our back to school program this year. It makes a huge difference to us in that we really believe that parents, teachers, SNAs, principals and children need an awful lot of help at this time of the year, and it's really important for us to do what we can. And that piece of funding has meant that we were able to do a parents webinar last month, and that we also are able to do tonight's webinar. And we've also been doing some media engagement and some, I suppose, some promotion of our services and of our back to school checklist to make sure that people like yourselves are aware of those services and know about them and can come to us for help. September is traditionally a really important time of the year in terms of asthma management. Clinicians would talk about this September spike in asthma patients, I suppose, using services, and also potentially sometimes needing not only to access their local GP or their out of hours GP service, but also perhaps to visit A&E or maybe to need a hospital admission. So it's a really key point in the year for children as temperature drops, they return to school, the normal cold and flu season, and all of those things, I suppose, in layers combined for children, and it can make it hard for children and parents, and obviously correspondingly for teachers, to manage asthma in a classroom situation. So what we wanted to do very initially was just to talk you through a little bit about the findings from the last webinar that we ran with teachers and SNAs. There's some very interesting results came from that. And I can't remember the numbers off the top of my head, but I think we had something like 17 principals responded to the survey. And then between the people who participated in the program and the people who participated in the webinar the last time around, I think we had close to 120 respondents, either teachers or SNAs. And what that told us really, I suppose, is that the program is really important, it's really good, and that you as teachers and SNAs really believe that it's needed. So the survey results indicated that 55% of yourselves felt that the program meant that they had gained additional asthma management knowledge. 89% of participating teachers believed that through the program they had been provided with the tools and the training that they needed. 78% of teachers gave a star rating of 4 or more in terms of how confident they would be in managing an asthma attack in the classroom. 45% agreed that the schools program had improved their overall knowledge, and a further 46% strongly agreed. So the maths on that one at 99% in total is very good. We're very happy with that. And 90% of people said they'd recommend the program to other parents or to other teachers and SNAs. And I suppose for us, what that means is, you know, when you do a piece of work and when it's new or it's tweaked from previous years, and you feel like those kind of results come back and tell you that you've gotten it right, I think it's really good. And some of the other results, I suppose, that really were quite stark for us, you know, were around the number of SNAs, teachers and principals who felt that asthma was a huge risk in their school, that they did not feel that they had enough knowledge about how to manage an asthma attack. 100% of respondents did not have access to an emergency inhaler available in their school, and people felt that their basic levels of asthma management were much lower than that what they would expect or would feel that they need in terms of the challenge they face in the classroom. So I might get Ellen actually to pop me on those few stats, because of the sick baby, I can't literally remember them off the top of my head, even though I did media interviews about it last week. But essentially, I suppose what it says to us is that this program is very needed, it's very urgent, and we will, and we'll touch this on this later on, we will be lobbying the Minister for Education and the Department of Health and talking to them about this kind of program and why it's so needed. But for a moment, if it's okay with yourselves, I will kick it over to Grace Ann O'Callaghan, and Grace Ann has joined us from Portmarnock, and she participated in the programme earlier on this year. And we thought maybe it might be a nice juncture at the beginning, just maybe for Grace Ann to talk a little bit about why she thought the Safe Schools programme maybe was of interest prior to doing it, and also maybe to talk a little bit about her experience of asthma. And what I might invite you to do, if you feel comfortable to do so, is to share either through the comment or the chat box on the webinar, or through emailing us on nurse@asthma.ie, is to share your experience of asthma in the classroom and talk to us a little bit about what you experience, what you think is challenging, and your concerns around asthma. Because obviously we used the programme that we ran earlier this year to generate some of the survey results, but we also want to be sure when we're making the case to government that this kind of a programme needs to be funded, that we're hearing your voice and reflecting your real need in the classroom. So you can feel free to do that either through the chat or through emailing us at nurse@asthma.ie. But for the time being, I'll kick over to Grace Ann just to talk a little bit about her reflections and why she thought this, prior to doing it, was a helpful programme.
Thanks very much, Sarah. So I guess my background, I've been a teacher in St. Helens Junior School in North County Dublin for 14 years, and we are an infant school with an autism unit. So I've been a post holder for the last number of years, and part of my role is coordinating first aid in our school. So that involves planning for things like asthma management and getting permissions from parents, taking photos of children, making sure they're displayed and that medications are kept safe and stored away. So when for this last number of years, I've been kind of managing this through research and speaking to people, going on courses, kind of seeking out information for myself. So when I got this opportunity to take this course with the Asthma Society, Safe Schools, I thought it was a great opportunity for me to get some answers, get some guidance, and just to kind of develop my own confidence in managing these the asthma in our school. Because of the fact that we are an infant school, children can't really advocate for themselves, and similarly with children in the ASD unit, they can't sort of describe what they need always. They don't always have the language, and certainly they might not have indeed the dexterity to give themselves their inhaler, and they may need a good bit of support with that as well. So planning for asthma in our school has always been something that would involve the teacher having permission to give medications, working closely with the parents, being trained to use the medication and the spacers. So it was great for me to take this course. I went for a whole day. We did the cardiac first response community, the pre-hospital emergency care course first, which was extra first aid, which was great. And then we did some work on administering the medication, how to do it correctly. And I guess what was a huge benefit to me was getting the answers to the questions that I'd had all along as the post holder for first aid and the coordinator, and then collaborating with other people from other schools who were in the same role or similar roles, deputy principals and principals who were managing these things in their schools and sort of sharing ideas. And then generally the main takeaway for me was this ability to apply for an inhaler to have in the school for emergencies. That once I get certified on this course, that I'm able to apply for that and to have on hand in case there's an emergency asthma situation that we can administer that. So overall, I guess from that point of view, I really recommended doing it. And my own confidence in dealing with asthma in the school was really the huge benefit for me. And just that sense of efficacy that I'm doing the right things and that I had the backup of the questions answered by the facilitator on the day of the course that I attended.
Great, thanks, Grace Ann. Just maybe to clarify for people, so there's a few, I suppose, steps in the Safe Schools programme, which we ran this year as a pilot programme. It was run across 4 CHOs, so 4 different healthcare areas, essentially. We had funding for 30 schools, so 56 schools actually applied for funding, and then we gave the places on a first come, first served basis. So we ran a webinar for teachers and SNAs that we opened out to as many people as possible, as many people who could dial in and who could join us, and we shared that on the website so that people could use that afterwards. I think we had something like 160 people registered in advance, and then about 120 dialed in the night. I think about 50 or 60 people have watched it down since, but I'm sure Ellen will be able to give me the exact stats, and we'll update you and let you know about that afterwards. But in addition to that, then we had the 8 hours of training for those 30 schools who participated, and then Ellen sent out a Safe Schools online pack to every school who participated as well, including all of the documentations, links, any of the website links, the videos, or the leaflets that we thought were of relevance. And then afterwards, Ellen is providing administrative support to people to make sure that the process involved in actually registering for the inhaler, having done all of that, gets sorted as smoothly as possible. And we'll talk through at the end a little bit of what the programme meant. Just to say thanks to Grace Ann, obviously, for coming on and explaining a little bit from her experience as to what it was like and what it kind of involved. And what we might do is, after Ruth has talked to us a little bit about the basics of asthma, we might pop back to Grace Ann just to see, when she's listened to anything that people are talking about, what's of relevance within that, in terms of any questions that she really felt were very solidly answered at the training, which would be really good. But what we might do for the time being is we will kick over to a video from Ingrid. And Ingrid is 8 and she's from Hoth, and she's going to explain a little bit about her experience of asthma. We thought it's quite relevant, and when we're talking about SNAs and teachers and parents, to really remember the patient voice and the child's voice and their experience of it. And that's really something that I suppose we try to come back to time and time again.
Hello, my name is Ingrid and I had asthma for 5 years. My asthma before it was controlled was pretty bad. Like, I couldn't go for runs, I couldn't go on my bike, I couldn't do any hip hop, I couldn't do athletics. I couldn't do like a lot of things, but you actually can if you can control it. Yes, you can. Like, you can pretty much do anything if you control it. What really helped me was I talked to the Asthma Society nurse on the phone, and she'd give me some advice. Just need to stop, take a break. If you're running, for instance, and you're just going, oh, my chest hurts, don't just keep running, just kind of stop. My mum told me to try do some meditation, and it just calms you kind of down. I used to be kind of nervous being at school because, like, if my mum or dad wasn't there or anything like that. Now I'm not really that bad because my asthma is controlled and there's nothing to worry about. If you want to find out more information on how to control your asthma, go to asthma.ie, and there's really cool booklets for kids.
1 in 5 children in Ireland has asthma. No child should miss out as a result of their asthma. We're here to help, guide and support you through our nurse advice line, our nurse WhatsApp messaging service, our website, and through a whole host of other supports that we can provide to you. You can rely on us to look after you.
Thanks for that, and thanks to Ingrid, obviously, for participating in that, and for reminding us a little bit of the flavour of what it's like from a child's point of view to have asthma in school and maybe to be worrying about it. And really, I suppose you can kind of see the relief and delight for Ingrid when she's gotten it under control and she feels much better. I've met Ingrid twice at this stage, and I have to say she's a much better advocate for asthma management than any of the other patients I know, or myself included. She kind of really gets it, and it's really fantastic to see. And she has had a very positive experience of getting great support from the teachers in her school, and from them really caring in the same way that any of you do about managing it, and knowing enough to manage it properly and support a kid like Ingrid, whose asthma can be challenging sometimes. What we might do, if it's okay, is we will kick over to Ruth, who is our clinical nurse respiratory specialist. Ruth works on our beating breathlessness nurse WhatsApp service. So essentially, where you can send a message in to Ruth or to Sam, who works 1 day a week on the service as well, and ask a question about asthma or talk about your experience of asthma and get some support back and forth. It's a chat service. You send a message and she'll reply. It works from Monday to Friday, 9 to 5. We will talk at different points as we go through about the different ways in which it can be really handy to use that service, because I think for teachers or SNAs in particular, you can use it actually to get a hold of the leaflets, the videos, or any other materials that you need, and save them down into your phone. So we might just flag that as we're going, because I think it's really handy for people to know about that. And then after that, we have 10 or 12 questions in from people in advance, but we will also deal with any questions from yourselves as they come through the chat function. So feel free to send in any of those questions that you have about asthma management as they arise or as they occur. occur to you. But I'll kick it over to Ruth for now. Thanks.
Thank you, Sarah. Good evening, everyone. So I'm going to cover some basics about asthma, different trigger factors, and then the different treatment regimes then that people, you will find that your children could be on potentially. So what is asthma? So asthma is a common condition, as Sarah said, it does affect 1 in 5 children, 1 in 10 adults. So it is a very common condition which causes inflammation or redness of the airways. Along with that inflammation as well, you kind of get swelling as well as the redness. So that could all cause all these symptoms. So the airways then are small tubes that carry the air in and out of the lungs. So as you know, when you take a big breath in or take any breath in, down the air goes through your trachea, through your windpipe, down into your lungs, down to your alveoli, and the air gets turned around and back out again. So, and again, what happens is then if the airways are really small and tight and swollen, that air, it gets in all right, but it can't get out. And that's where the symptoms come into play. So the airways become oversensitive and react to things. So that's why there's so many different triggers for asthma, and not every child will have all triggers, and every child's triggers are different. There are some very common triggers, which I'll talk about later. But the majority of things like running around and dust, I suppose they're the big ones, so we'll talk about them later. So as I said, cold air is the other one, particularly this time of year now, we see the changes in temperatures, and that's in WhatsApp in the last, I'd say, 2 weeks. All the queries that have come in have all been parents of children with asthma. It's just been, and it happens, you know, all the time in September, because that's when the problem time is. We're always concerned about September and March, where you have the changing of the seasons. They seem to be the problem times for people with asthma. You know, that's when the airways become oversensitive.
Ruth, you're actually gone on to silent there. Just that I'd say you might have pressed that button accidentally.
Okay, sorry. Okay, so this is a little picture of the different airways. So you see over there on the left-hand side, you have, that's a normal looking airway. So this is, it's like a tube, you know, like we do actually have kind of tubes as pictures to show people actually what's going on in their airways. So you can see there, the airway is nice and open, air is getting in and out there, no problem. And around the outside there, you have the muscles, and those muscles are nice and relaxed, and everything is perfect. Then you get an asthma airway, and this even when asthma is controlled, this is what people's airways are like. So even though your asthma is 100% controlled and you're very well, the airways never ever go back to being normal. And this is, you know, people can't figure this out why, you know, like I'm taking my inhaler, so, but you still have all this, you know, the swelling is there, there is underlying redness there as well. And sometimes then the wall there, you see the little red dots, that all can swell up as well and cause all sorts of problems. And then when somebody then is having an asthma attack, this is the one over here on the right hand side. So you can see there that the lumen of the airway, or the hole there, has got really small. So you can imagine the air trying to get out through that, and that's where you actually get the whole wheezing. So it's the air it's being pushed out through that hole. The other thing that happens is that that muscle that was nice and relaxed is now very tight, and it's constricting, and that's why sometimes children will complain of having a tummy pain or a pain in their chest. That is why they're actually experiencing that. It's because those muscles are gone into spasm, and it's like any other muscle in your body, they go into spasm, so we have to relax them. The next slide, please, Ellen. Okay, so your symptoms then. So there's 4 different symptoms. Now you have to remember that not everybody has all these 4 symptoms. So children, they won't all complain of the whole 4 symptoms. Some of them might, but some won't. But in order to have a diagnosis of asthma, you have to have at least 2 of these 4 symptoms. So a cough that doesn't go away usually occurs during the night or very early morning. And as kids always get up early in the morning at 5 and 6 o'clock, that's when their symptoms can be troublesome. It often happens during exercise as well. And that cough, it tends to be a dry cough. It's not a productive or a phlegmy cough that you would see with the nasty chest infection or that. So it is kind of a dry back, you know, hacking cough that kind of, you know, sometimes you just feel like saying, well, just give a good cough there and get rid of that, but they can't, okay? Because you have that redness in the airways, and you have the little hairs in the airways. Remember, you have little hairs there in your nose, we all know have them. So your airways are actually lined with those hairs as well. So that they all get irritated and angry whenever they inhale something, and that's what triggers the actual cough. Then we have shortness of breath, and this is just basically can't get your breath. Then you're wheezing, which is a whistling sound, and it's always on the outward breath. If a child is actually wheezy on the inward breath, that's not asthma, and it's more than likely to be croup or something else. So, you know, that's, I suppose, another warning sign to watch out for, kind of, I suppose, you know, that it's always on the outward breath that it is asthma. And then as you have the chest tightness or tummy ache in the smaller kids. They kind of, sometimes smaller kids can't differentiate, or maybe a child with special needs can't actually differentiate between their chest and their abdomen, and where their pain actually is, what their tightness actually is, and therefore they will often complain of a tummy ache. So as I say, they're the 4 symptoms, so you don't have to have all 4, just remember that. So causes of asthma then, so basically, I suppose, so far we don't really know what the cause of asthma, but there's lots of bits of theories flying around the place. So obviously genetics has a huge thing to play. So if you have a brother, sister, mother or father that have asthma, you are highly likely to get asthma yourself. So that's always the thing. Onset is usually in childhood, again, but people can develop asthma in their adulthood as well. But usually it is in childhood. Climate has obviously has a huge impact on it. And we don't know why that is, because it doesn't matter where you are in the world. There seems to be higher incidence. For example, in Australia and New Zealand, they have a very high incidence. In fact, their incidence of asthma is actually even higher than we are. We're 4th in the world. Australia and New Zealand are ahead of us, and the UK are ahead of us. So I mean, so therefore the climate, I know New Zealand probably is a similar climate to ourselves, but like the Australian climate is different as well. So the warm sunny weather doesn't seem to have a huge impact on it either. But then if you go to Spain or Portugal, then people would say to you, well, actually my asthma is better when I'm abroad. So again, we don't really know. It is linked to allergies and allergic diseases. So again, if you have eczema as a child, you're highly likely to develop asthma. If you have hay fever, you have an 85% chance of getting asthma as well. So the two do run side by side. And we always ask about, if somebody does have hay fever, we always kind of question about their chest as well, because they say they will go on and develop asthma. So those 3 conditions actually are like sisters. They're so closely linked, because what's going on in the airways is the same thing that's going on in the skin and eczema and in the nose and in allergy. Then our modern lifestyles, and this is kind of things like, all our houses now are airtight with double glazing and triple glazing. Yeah, it's lovely and warm, but it's not great. It's not very healthy, to be honest. We've very limited air circulating, and we've seen that in recent times through COVID. We need air and we need ventilation. So again, things like our central heating in our houses, and there shouldn't be radiators on in bedrooms of kids because they don't need them. Things like that, which we'll talk about later when we're managing the trigger factors. Then your risk of actually developing asthma is increased if you smoke during pregnancy. If you're overweight, you are at an increased risk of developing asthma, and that's a relatively new phenomenon. If you have a history of viral respiratory infections, you're more at risk of developing asthma also, and it's a family history there, as I've said already. So the next slide, please, Helen. So when we're actually diagnosing asthma, it can be sometimes very tricky to diagnose asthma. We never diagnose asthma in children under 2, because there's so many other conditions it could possibly be. And even children under 6, it's actually very tricky. And sometimes it is a wait and watch situation, and we put people on treatment or kids on treatment and see if it works for them or doesn't work for them. That sometimes is the way, because with children under 6, a lot of the blowing tests that we get them to do, like what this guy here is doing, that's called a spirometer test. If you're under 6, you can't do that test. And even if you're under 8, it can be quite difficult to do. We often use a peak flow test, which you may have seen people doing those. They can be done on children over the age of 6. But we always kind of take a good family history, because that's a real indicator. Look at the pattern of symptoms again as well. Is there nighttime symptoms? Is there symptoms during exercise? Are they kind of just coming and going, or are they a regular feature? So sometimes we ask people to keep diaries. Again, we would often examine the child's chest. Sometimes if the asthma is very well controlled, or they have no symptoms whenever they come in to see us, the chest examination could be perfectly normal. We never do chest x-rays unless we're thinking of something else, because again, most children that have asthma, even when they've been diagnosed, their chest x-ray will be totally normal, and then all we're doing is exposing them to radiation that they don't actually need. So we don't do chest x-rays routinely. And then the trial of asthma treatment is usually the way we would diagnose asthma, particularly in the under 6s, but very often in the older child as well.
Ruth, I just think maybe it's worthwhile just resting on that point for a little bit, because I do think it actually has a relevance to the parent-teacher relationship and to the kind of briefing sometimes that teachers might get from, or SNAs might get from a parent. And I think actually probably the complexity around diagnosing asthma and the kind of let's treat it and let's wait and see kind of concept, even though medically that makes great sense, it actually makes it quite difficult sometimes for parents to communicate on with the teacher, because what you'll find is, and sometimes we hear this either through the WhatsApp service or to our advice line, is that a parent will say, oh, but the doctor said maybe we'd a touch of asthma, or the doctor said we didn't know if you had asthma and we'd see if they had, or that we'd query asthma. And so I think that makes it quite difficult, because the teacher or the parent may not feel, oh, I should definitely tell the teacher we have asthma, because they might feel like, well, I don't know if we do. And so I suppose it's one of the things maybe that we might encourage a teacher, if you hear a child talking about having an inhaler and the parent seems to be unsure about it, well, first of all, you can always refer them on to our services if you think that a parent might find it of value to talk through that process with us, because the diagnosis process is kind of hard for people to understand, but also for a teacher to understand. The reason why that is the case is it's not like the doctor or the nurse mollycoddling the patient and saying, Asher, we'll see how it goes, treat it with asthma, we don't know. It's because the diagnostic process doesn't really facilitate that, particularly in children. And I think maybe, I don't know if you've any advice for teachers specifically, but I do think it's useful for people to know that that's why they might see an uncertainty from parents, or also sometimes maybe why the parent doesn't feel 100% sure about telling the teacher. So you know, I suppose a good conversation there can really help, at least for the teacher to know, look, they are treating it as asthma, so that, you know, and in that instance, obviously you should have all of the medications, you know, that child should be bringing them and everything. And if there's any debate around the diagnosis, that shouldn't mean that that you shouldn't have the medications in school, if that makes sense. Sorry, I'm not articulating myself very well.
Yeah, it's a very grey area. It's a very challenging area, diagnosing asthma, because at the end of the day, you don't want to be diagnosing a child with asthma and putting a label on it, because it can actually, you know, reflect on their life later on in life and become a teenager, or even when they go start applying for different courses and jobs and things, because it can actually impact on that, whether they join the army or the guards or whatever. There are stipulations there that you can't enter into. So that's why the reason why GPs or doctors are actually slow to actually maybe, and it's not that they're being slow, they're just being cautious. Because it is such a complex procedure. It is a complex condition. It's not straightforward. Everybody just thinks, oh yeah, look at his asthma. And this whole concept of a touch of asthma, you know, I think we need to get it moving away from that, and the whole concept of mild asthma, because as far as I'm concerned, and a lot of my respiratory nurse colleagues are concerned, there's no such thing as mild asthma. You either have asthma or you don't, until you know, and you're diagnosed with it, and you're therefore at risk of the same asthma attack as somebody that has severe asthma. It doesn't matter. You know, so you know,
it's one of the biggest barriers that we see for patients or parents or kids to manage the asthma, is actually accepting that it's a real diagnosis and that it's a real condition. It's not a touch of a condition. It's actually one of the real barriers to helping people understand, no, this is real, I manage it, here's the important bits and pieces, is because people can be quite dismissive about it. So I suppose what we'd encourage is that any teachers, if they're coming across it, that you know enough to know not to be dismissive about it, or if you think you're experiencing that, you know, you can refer somebody on to us to get some guidance and support, so that they know enough about it that they don't dismiss it, I think.
Yeah, exactly.
And I won't interrupt, sorry, go on.
All right, sorry. Just wait to get back to the presentation. Oh yeah, we're on to asthma. Yeah, so I mean, again, if a parent comes into you, look at this child has been to the doctor, kind of they're questioning that it might be asthma, but he has an inhaler, so you treat that from a teacher point of view. You should try and treat that as if the child actually had asthma, because you know, the child is obviously experiencing symptoms, or could be potentially experiencing symptoms. So you still have, the child gets wheezy, they still need to get their blue inhaler. You know, that's the bottom line of it. So you don't just ignore it and kind of just say, you know, I know they're only questioning whether he might have, you know, if the child has symptoms that they need to be treated. So again, asthma management, something else came into my head there now to say it, and it's gone, but I'll come back. So while asthma cannot be cured, proper management can control the disease and enable people with asthma to enjoy a good quality of life. So again, that's the other thing, I suppose. Yes, I know what the thing it was I meant to say to you was that even though 1 in 5 children, yes, get asthma, that doesn't mean that they're all going to experience acute asthma attacks. Not every child gets an acute asthma attack, and I've met several people that have gone through life never having had an acute asthma attack. So again, don't kind of think, even if you have a class there with 6 or 7 children with asthma in it, that doesn't mean they're all going to get acute asthma attacks. You know, the chances are, you know, they're probably not, but it's still important obviously to know what to do if they do get one. So that's the other thing. So don't be fearful and don't get afraid this is going to be horrendous. You know, it's like a child with epilepsy. Like, you know, not all children with epilepsy will actually have a seizure in front of you either. So, you know, so And the parents will know, and you will get to know the kids that are maybe more at risk of having an acute asthma attack as well, because 85% of people that have asthma don't have severe asthma. So about 80 to 90%. So it's actually only a very small percentage of the asthma population that actually have very severe asthma, that are maybe in and out of hospital on a regular basis under the care of consultants and that sort of thing. So that's just to bear that in mind. So we don't want to frighten the life out of you either. So in terms of asthma, that asthma cannot be cured. Proper management obviously can help control the disease with good inhaler technique and an asthma action plan, and we'll go through that later as well. And there's no reason why these children can't be out running around the playground like any other child. One thing to watch out for actually is that if there's a child that doesn't want to be outside or doesn't want to maybe take part in sport in school, is that because they're afraid of their asthma? Is it because, or is it, we often hear, this child that wants to be carried around all the time, the lazy child. Is it because of their chest, or is it because they just genuinely aren't interested anyway? So that's another one that, and children sometimes can play on these sort of things as well. So just to watch out for that. Most people with asthma will require regular medication. So that's what we call their controller medication. So we'll go through that later. And good management then usually involves both medication and lifestyle interventions, such as trigger factor avoidance and using their asthma action plans. The next slide, Ellen, please. Right, so this is our controller medication. So these medications, you more than likely are not going to see these in school, because they're taken morning and night. They don't need to be in school, to be honest. So they're usually a brown color. I always call them the autumnal colors. They could be brown or orange or purple or that sort of color. So they're, as I said, they're twice a day. They're twice a day, every day. They get rid of the redness and swelling in the airways. So it's like you get a bit of hydrocortisone cream, for example, and you put it onto an itchy spot in your arm. That's how they work. So there's a little bit of steroid in them. They get down into the airways where they're needed, and hopefully they will reduce that redness and swelling. And the effect of them builds up over a period of time. So it's like that if you actually take this inhaler when you're actually wheezing, and it's not going to relieve you there and then. So that's when our blue inhalers come into play. And typically they're required to be taken twice a day, morning and evening. Some children might only be on them once a day, but the majority of people are actually on them twice a day. And the important thing is that they're taken when the child is feeling well. Regardless of how, if they're 100% well and have been for the past 6 months, they still need to take their inhaler every day. That's the one that keeps them well. And then this is the reliever medication, or the rescue medication. These inhalers always tend to be blue in color. So they're used to treat symptoms of an asthma attack, or maybe not even an asthma attack as such. They could even just be there to relieve some wheeze. So again, they can be taken to relieve any sort of symptoms at all. Any wheezing, coughing, shortness of breath, or the tightness of the chest, they will be taken. They will work immediately in 5 minutes. They will work. They last in the airways from 4 to 6 hours, and so therefore then they do need to repeat it again if needed, but hopefully there wouldn't be. So again, sometimes some children will take these before they go out to do sport. That's quite a common thing. Reliever medication, then it relaxes that muscle. So if you remember going back to our little chart there with the muscles around the outer airway, so they all will relax whenever you take this airway, but they do nothing for that redness and swelling that's actually in the airways. So they open up the airway, so it makes it easier to breathe. So that's how that blue inhaler works. So again, this is the important thing. This is the most important thing with children, that spacer devices are used with those inhalers. So using that blue inhaler directly into your mouth, actually you get between 0 and 10% of medication into your lungs. Even with adults, using those inhalers into the mouth, it's the same thing. 0 and 10% is all you're going to get into the lungs. So if you use this device here like a spacer, the most common one you'll see is the yellow one up there. They tend to be yellow for children, they're orange for infants, and they're blue for adults. And there's a green one, I think, or a purple one as well, that's often used for kids too. So again, this device, then you put the inhaler into the end of it, and we're going to show you a video on how to use this. But the inhaler goes into the end of it, you press the inhaler once, and then the child breathes in and out through the device for about 10 breaths. So it just makes it much easier for you to use the inhaler, so you can be guaranteed then the medication is going to get into the lungs. Ellen, I'll just get you to hit the return button there. I think the next few bits come up.
Sorry, it's possible maybe having a technical link, difficult to go into the video. I suppose just to reiterate one of those pieces that Ruth is saying there, I mean, you know, when I do radio interviews, or I talk about the asthma experience, and I talk about the importance of inhaler technique, people sometimes kind of scoff and they half laugh because they think it sounds like a mad notion that you'd need, you know, a lesson or to learn about how to take an inhaler. But actually, children who have asthma, or their parents, their teachers, their friends, they actually need to know about how to take that inhaler properly, because it's a little bit like being handed a tablet, but actually breaking the tablet in three and saying, I'm actually going to take this amount of it. And the spacer device is absolutely wonderful for making sure that a child, even if they are a little bit more stressed or if they're finding it difficult to breathe, even in those instances, they are getting more of the medication right down into their lungs. Really good, what they call, you know, professionally, drug delivery. That makes sense. That makes sure that the medication is getting right down there to make sure that the symptoms they're experiencing can be alleviated as quickly as possible. And so inhaler technique is actually a really important part of our work. Even though people think the notion is really mad, it's actually really important. And so when we're talking to schools and we're talking about the need to have an inhaler in the school, we're also talking about the need for that inhaler to be accompanied by a spacer device to make sure that actually that can help the child as quickly as possible in the event of you needing to. And I'll kick back over to Ruth there, sorry.
Okay, and we're just, hopefully this video now will work for us. So we have this video here on how to use the Aerochamber.
Now I'm going to show you how to use the Aerochamber Plus device using the multiple breath technique. This technique applies irrespective of the medication delivered in the device. Remove the cap from the metered dose inhaler and shake the inhaler. Insert the inhaler into the back of the Aerochamber Plus. Put the mouthpiece in your mouth between your teeth and close your lips around the mouthpiece, or place the mask over the nose and mouth. Press the canister once to release a dose of the drug. Breathe in and out to fill your lungs each time. The flow view inspiratory flow indicator on the Aerochamber Plus moves towards you if the device is used correctly. If a whistling sound is heard, this indicates that you are breathing too quickly. Continue breathing in this manner to allow time for 5 breaths to be taken. Then remove the mouthpiece from your mouth and breathe normally. Remove the inhaler from the Aerochamber Plus and replace the inhaler cap. If a second dose is required, wait 30 to 60 seconds before repeating the process. Especially if using a controller inhaler, remember to rinse your mouth with water after use.
Sorry, we have a little bit of background noise here. I just think what should be hopefully really reassuring for teachers is if you do have to administer an inhaler in the school situation, is that, you know, there's a slow kind of approach to that that methodology, and also that you're not expecting to administer the inhaler and that it works in 3 seconds. The idea is you can take it slow as the teacher with the child, and that they have more than one you know, instant or moment to get the drug delivery right down into their system. I think that's quite reassuring for any teachers who are experiencing that. But Ruth, I'll kick back over to you again.
Okay, so again, if anybody actually wants that video, please just send me a message on WhatsApp and I can send it to you. You know, you can have it on your phone, which is probably a very useful thing to have on your phone. Likewise, with this 5-step rule, again, if you send me a message on WhatsApp, I can send you this graphic. These are really it's a really handy graphic actually to have on your phone. You can actually print this off and have it as a poster too, if you want to put it up in your schools as well. Have one maybe in every classroom. It's no harm to do that. So basically the 5-step rule then is what we do whenever somebody's having an acute asthma attack. So the important thing is to sit up and stay calm, do not lie down. And that kind of, you know, is sensible enough, because if you lie down, you're not going to be able to take a slow, steady, deep breath. So nice, sit up nice and straight, get the child to take slow, steady, deep breaths. Then you give them 1 puff of the reliever inhaler, which is usually blue. For people aged 6 and upwards, it's up to 10 puffs in 10 minutes. So you're going to give them a puff, and you might think that's an awful lot, but in an acute asthma attack situation, it's not. So you give them a puff of their blue inhaler every minute for 10 minutes. For children under 6, it's up to 6 puffs in 10 minutes. So use the spacer, definitely use the spacer in this situation, because if somebody's having an acute asthma attack, they're going to be wheezing a lot, they could be quite short of breath, they could even be coughing a lot. So, you know, using an inhaler directly into the mouth in that situation, you can be guaranteed that no medication is going to get into the lungs. So again, use the spacer. And, you know, there are some tips there as well. If you don't have a spacer, actually, you know, you can actually get a disposable coffee cup and punch a hole in the bottom and put the inhaler into it. You know, I've recommended that several times. You know, if you're out of a situation where you don't actually have a spacer, but you know, if you're involved in this Safe Schools program, you will actually have access, hopefully, to a spacer as well as the blue inhaler. And again, you know, I suppose when we're asking children to bring their medication to school, we would always recommend that they bring their spacer as well as their inhaler, and they keep them in the wee box, maybe on their desk, whatever. We can talk a bit about that later. So go back there to the step 4. Ellen, if you wouldn't mind, please. We only just did step 3 there. So you're going to give the inhaler 1 puff every minute for 10 minutes. And so step 4 then, so while you're doing that, you can send somebody off then to ring an ambulance. So you can ring the ambulance, either 112 or 999, and definitely call the parents as well. And hopefully you're not living like me in Leitrim and you can wait up to 2 hours for an ambulance. But what you do is, you know, you kind of, when you are ringing for the ambulance, the important thing is to say that this is for an acute asthma attack, because then that will actually speed them up a wee bit getting to you. And then what you do then, repeat step 5. For step 5, you repeat step 3 if an ambulance has not arrived in 10 minutes. So you're going to go back and give more of the inhaler. So just remember that. Don't fear that you're actually going to be giving too much medication. You're not, because in this situation, you can't give enough Ventolin. And whenever someone is having an asthma attack, don't ever leave them on their own. And extra puffs of that blue inhaler are safe. So don't be worrying about that. I mean, the worst thing that can happen actually is maybe the child gets a little bit hyperactive, or their heartbeat might fasten up a wee bit. That will all settle down again, so don't worry about that. So we actually have a video here now of the symptoms of an asthma attack, and hopefully this one will work too. But yeah.
Just maybe while we're waiting for that to play, so the WhatsApp service that Ruth mentioned is available on 086 059 0132. So that's 086 059 0132. And any of you can feel free to send a message on WhatsApp to it this evening, and Ruth will follow on with some of the resources. So we can send you through any of the videos that we've played tonight, and you can just press the save button in WhatsApp and you'll save them down into your own gallery in your phone. We can send you the images of the 5-step rule, and we can send you some of the links to any of the literature. And those are things that teachers found particularly helpful after the webinar the last day. They sent the message to us this evening. Ruth or Sam responded the following day, and we sent you the resources that you might need back and forth. But the other thing is, you can obviously share that number with any of your work colleagues, so that every single one of the team, whether it's across the SNAs or the teachers in the school, have access to those, and they're saved on their mobile phones, so that people feel calm and they know that they have that information available to them at their fingertips right in the classroom, should they ever feel that they need it. And that's one of the things that the service is there for, is to make sure that you have that, and that we're using that to push that information out, and that it exists with you on your phone, just to kind of keep you at ease if a situation like that occurs. But I'll kick it back over to Ruth there.
Yeah, just before we start this next video, just a little question came in there on the chat about expiry dates on Ventolin. Yes, there is an expiry date on Ventolin. It'll be on the box. There's usually about maybe 2-3 years of an expiry date, so don't be they're not going to go out of date that quickly. And even if it's out of date, even by 6 months, it still, it still will work and still quite safe to use it. So don't kind of get too hung up on, maybe if it's 4 or 5 years out of date, yes, then yeah, it might be that effective. But certainly, yes, as I said, the expiry date that's actually on these inhalers tend to be maybe 3 years at the most.
I just saw a question come in there from Kevin, so he asked about that number. So it's 086 059 0132, and we'll share that with you with the notes after the webinar, but we'll also make sure that it pops up on screen as we're going down through.
Symptoms of an asthma attack can include one or any combination of the following: coughing, wheezing, shortness of breath, difficulty finishing sentences, chest tightness, or lips turning blue. If you feel an asthma attack coming on, or are with someone who does follow the 5-step rule, Step 1, sit up and stay calm. Do not lie down. Step 2, take slow, steady breaths. Step 3, take 1 puff of a reliever inhaler every minute. This is usually the blue inhaler. Children under 6 years of age can take up to 6 puffs in 10 minutes. People over 6 years can take up to 10 puffs in 10 minutes. Step 4. If the symptoms do not improve after 10 minutes, or if you are worried at any stage, call 999 or 112. Step 5. If an ambulance has not arrived after 10 minutes, then repeat step 3. Remember, if someone has an asthma attack, do not leave them on their own. Use a spacer if available, and make sure they see a healthcare professional afterwards. An asthma attack is an emergency, so act now.
And that's one of the real important things there, is about actually visiting a health professional after an asthma attack, because we need to always kind of figure out why this asthma attack happened and try and avoid ones in the future. That's the big ones. So we might just go back to the presentation, because I'm hoping now that the
So just to say, we did a little bit of research with Amoric Research during the year, and we got the data back in July. And what it told us is that only 12% of people in Ireland know about the 5-step rule, which is pretty stark and pretty shocking, and is something that we are very concerned about. So for us, I suppose we're really fixated on how can we, even with our funding challenges following COVID, how can we make sure that we're getting that message out there? So I suppose for you as a person who has taken the trouble to dial in at 7 o'clock on a autumn evening, we would say that people like yourselves are really important to us. So like I mentioned, if any of your team members want to use the WhatsApp service to get that information sent through to them, or if you want to use our asthma advice line, we can send you through those links afterwards. And really, I suppose for us, we'll be fixated on trying to get as much funding as possible so that we can run the kind of really big communications campaigns that we need, so that every single person in Ireland knows how to manage an asthma attack, that they know the 5-step rule exists and they know about it. In the same way that people know how to recognize the symptoms of a heart attack, or they know how to recognize when somebody's having a stroke. We think it's a really important public health message, particularly for any of you who are dealing with children, because 1 in 5 of them will experience asthma at some point in their childhood. So it's a really big healthcare problem, particularly for this particular age cohort. And just to say, obviously that's 086 059 0132, and that's using the WhatsApp messaging service. But you can also call us if you have any child with a particular challenge in your classroom that you want help and support on, or if you want to learn the basics of asthma, or to have anything that Ruth is talking through tonight reiterated or explained to you, and we can set up an appointment with the asthma nurse, and they're more than happy to support any teachers who are finding that they may have a challenge in the classroom around asthma management that they're concerned about.
There was a question that came in there in the chat as well about a cough bottle, using cough bottles for asthma, acute asthma attack. No, absolutely no, they will not work. Cough bottles are of no benefit to asthma whatsoever, because they won't get rid of that redness and swelling in the airways. Now I'm just going to see there, we had a slide actually on trigger factors, which I didn't address earlier on. I don't know where it went to, but just to be aware about triggers. And that's one of the first things in terms of asthma management, and avoiding trigger factors. So things like the cold air, hard to avoid, you can't, but you can put wear a snood over your mouth and nose going outside in the cold air. That will help. And also, the dust, and they're all big triggers as well. That can be. So again, obviously kind of, sometimes with chalkboards and that obviously can be a trigger in schools. Using markers and that, on whiteboards, that actually, those strong smells of those whiteboard markers sometimes could trigger an asthma attack in some children as well. And any strong smell will, so especially at the moment with all the hand hygiene and the disinfectants and the hand gels, they can be big. They could potentially trigger. There's me trigger. Thank you, Ellen. So they're just a few different things. They're about what we have: 4, 8, 12, 15, 16, 14 different triggers there, and these are the most common ones. So we have the smoking. So that's more passive smoking in relation to children. So if mother or father or brothers or sisters are smoking at home, that actually can make their asthma worse as well. Animals, this one kind of is just one, like the dogs, cats, etc. Not every child will have a sensitivity to animals, but again, it's one that we always kind of watch out for and educate children and parents around as well. Exercise is a common one. So the child actually starts running. It tends to be, the one thing about exercise and asthma is the asthma symptoms tend to come on after exercise, not during exercise. If the asthma comes on, or if the symptoms come on during exercise, that's the chances are that's actually something else. And there are a few other kind of unusual conditions that actually can develop as a result of exercise, and kind of similar symptoms to asthma. So not everything. The other thing that we were always told when I was doing my asthma education on courses, that not everything that wheezes is asthma as well. Remember that. So there are multiple causes for wheezing as well. Colds and flus at this time of year are very common, obviously, as the change of seasons. And grandparents and the older generation used to always say about the weather is that, it's the changing of the seasons. So it's the budding of the trees, that sort of thing, and the falling of the leaves are the times of the year that asthma, and we know that September is particularly problematic, as is March. Some medicines actually can trigger asthma as well. Things like ibuprofen or Nurofen can be a trigger. So generally we advise parents not to give ibuprofen to children that actually have asthma, because now it's a relatively small number of children that will actually have the reaction, but we don't know who those children are. So we tend to avoid them using Nurofen if they can at all, and just use paracetamol or Calpol if they need it for temperature management or for aches and pains or whatever they might be using. Feelings, obviously, and emotions. So feelings, I know you often hear, you may even have heard, children actually that take into a fit of laughing, that actually can trigger asthma. And can, if they get the other way, if they go very upset or if they're stressed, that actually can trigger asthma. And we do have a lot of resources there on anxiety management. And that for children maybe that are going in, transitioning into secondary school, and that can be a very anxious time for them. So we do actually have some resources from our previous webinar that we did with Aoife Lee, a psychologist, and we can send those to you if you have any concerns about that. And we can
actually, Ruth, I noticed we did actually have a question from Margaret, who's asking about how to help a child transitioning to secondary school with very bad anxiety due to asthma.
Yeah, so if Margaret, if she's on there tonight, if you wouldn't mind sending us a message on WhatsApp, I can actually send those links on to you. That might actually help. And local honey, good for asthma. Again, there's no research around that. Again, anecdotally, it is actually has been very useful for hay fever type symptoms. And some people will actually tell, if they do it, and definitely they're not going to, it's certainly not going to do any harm, but it certainly is not a substitute for inhaler medication or controller medication.
So we've quite a few questions in advance, Ruth, and some of them are really good questions actually. So I might kick over to those shortly, but just in the meantime, we might just do a quick reminder to people of the Safe Schools program, if that's okay. So Ellen had a slide there that had a few of the details on it about the schools program. So like I mentioned, it started out with the Safe Schools webinar, really quite similar in format to the one we were running this evening. Then we had the Safe Schools Training Day, which is available to the 30 schools that we had places for. As I mentioned, we had 56 schools apply for it. So that was based on the fact that that was a small allocation of funding we had from the HSE. And then we sent out the online Safe Schools pack, and Ellen is doing whatever support she can to schools to make sure that they're actually able to now register for the inhaler now that we've gotten the certs through in terms of the first aid training at the moment. I might kick it over to Grace for a moment, just to see, or Grace Ann for a moment, just to see if there's anything that has cropped up in terms of what Ruth was talking about that Grace Ann felt was also covered in the first aid course, or if there's anything that's kind of prompted or reminded her about this. And I suppose maybe one question that I think might have come in might have been, I think I saw somebody asking there about the availability of taking medications in schools, and are teachers allowed to give those medications in schools. So Grace Ann, do you want to touch on that a little bit?
Yeah, so primarily one of the things that jumped out there while Ruth was talking was it just triggered with me the outward breath and the wheeze. And I remembered being at the course and everybody saying, oh, all at the same time, wow, that's so interesting. And it's those little nuggets of information that are like really useful when they come up on a day like that. Then another thing I remember being really useful was the parents training the teachers how to use. Was that enough? Should we be getting a GP, or is it enough? And our facilitator was telling us that the parent training us is enough. Then the importance of the spacer and the incorrect use of it, and Ruth went into detail about how important that is, and that was made kind of very clear to us that how useful the spacer is and how important it is. And I actually went back after the course, and I had a little girl in my class and she was using the spacer, and I felt so much more confident, and so I felt it was so much more like important to give the time to it. And I could feel, as we're going through that with Ruth there, teachers kind of saying, oh yeah, but like we've so much to do, how can I be standing? It is just so worth it to give that time to get the medication correctly in order to help the child to access the rest of the day and the sports. Then what you were saying, Sarah, about the medication and giving it in schools, as far as I'm aware, we've always had a policy for medical administration, and it was around that once you get indemnity from the parents and it's given in a letter to the board that you're okay. Obviously, people may need to check that with their own board of management and everything, but that's how we've done it in the past. And it's one of those things, as a post holder, that you're looking for that information in order to be able to give it to your own staff and to kind of stand over it. So that's always what I've worked off anyway.
Yeah, and I think, Grace-Anne, that probably reflects our experience of it, which is that the nurses who deal with the advice line appointments, or Ruth or Sam who work on the WhatsApp service, they would hear from teachers and from parents who are experiencing a whole wealth of different responses when it comes to taking the medication in class. So in some instances, we have parents who say that they have to travel into the school to give the inhaler. In other instances, there are people like yourself who are like, okay, I've done the course and I feel confident to administer it, or they've spoken with the Board of Management, they've got a really clear protocol about what's appropriate. And I suppose the concern that we would express, which is why we think the Safe Schools programme is so necessary and why we're seeking the meeting with the Minister, saying, look, this is actually problematic because not every child is getting the same support, not every teacher is getting the same level of advice and information, and not every parent is getting the same reassurance that their child is safe in school. And that's actually not really safe or good or sensible. And so I suppose this is the reason why we think webinars like this can be really helpful for teachers to share that information, but also, like, we think you need a piece of structured support as teachers and SNAs to have that information to your hand, at your fingertips. And we think that's a really important piece about safety in schools, and we will be doing our best to talk about that. But if you are in touch with any of your local TDs, or if you're filtering this back, we think it's also an important point that you use your voice and say, look, as a teacher, I need more help on this because it is happening in schools and we have to keep kids safe. So I suppose that's part of what's driving and motivating us, is that we're seeing different levels, but you can always use either the WhatsApp service on 086 059 0132, or the service, the WhatsApp, the advice line on 1-800 44 54 64. And if you give us a call, either Ellen or Evie who work on that will set up an appointment with one of the nurses to guide and support you through. And the point is that those services are there to help people, including teachers. But I suppose for us, we really think that like this, we need this program. Like, teachers need this program, SNAs do, and kids need them to have it because they should just have that information at their fingertips. What I'll do is I'll kick over to 2 or 3 of the queries that I think Ruth might want to touch on. And Grace-Anne, if any of them occur to you, feel free to unmute and to weigh in on the off chance that anything that you've learned was helpful as well. Erna and Michelle are asking about how best to help somebody having an asthma attack. Now, hopefully the video of the 5-step rule, which we can share with you, as Ruth mentioned, is obviously one piece, but we also have that printed on a card. And when we are, fingers crossed, hopefully able to be back in the office and across the flow of things, if any of you want to send an email to nurse@asthma.ie, we will send out the stuff to people in the post. But also Ellen will be sending out an online asthma pack to any teacher who's participating in this evening. So we'll send you those materials electronically, and that hopefully Erna and Michelle should not only answer the question for tonight, but should give you the materials so you know it for good. And then Pamela and Angela have asked, what do you do if a child has an asthma attack and has forgotten their inhaler? So I wonder, Ruth, is that something that you have some guidance on?
In the ideal world, every school would have a blue inhaler and a spacer in the ideal world, and they can use that. And then, obviously that spacer, then you can't take it off and use it on another child. So you would, the sensible thing to do will be actually to give that spacer to the child and then go to the pharmacy and get another one. You can actually buy the spacers over the counter. You don't even need a prescription for them. You can just go in and get them. So I mean, they're not hard to get. It's the inhaler is the issue, because it has to be given to you or prescribed by somebody. So so if you end up using a spacer on a child, if you have a spacer in the school and you use it on the child, just give that spacer to that child or to the parents, and they can bring it home and they will get use of it, because they'll think these spacers actually have to be changed every 2 years anyway. They don't last forever. So don't throw them out, because they can be dear enough, some of them. So so yes, in the ideal world. Again, if a child is having an acute asthma attack, it is an emergency. So if another child actually has an inhaler there, just use it, give it, because, you have to do something. You cannot, this child is not going to get better without something. And just call the parents as quickly as you can, and hopefully they're nearby and they can get to you as quickly as they can. Yeah,
and I suppose the whole point about the Safe Schools program and doing the first aid course and then getting registered for the inhaler is that what we want is that this is happening as little as possible. And I suppose we've recognized that problem situation where it may be that the parent wasn't organized that particular morning and the child doesn't have their medication, or maybe they had run out of it, or the child may not be able to speak and they may not be able to tell you where the medication is. So we just think that registration process of having the inhaler in school is so important, so that regardless of what's going on at home or at school or with any of the logistics, that the child is kept safe. We think it's really important. And like I said, we'll be doing the lobbying at the highest level we can to talk about about that. Nancy has a really good question, which is, how do you keep a child calm during an asthma attack? Ruth, I might kick that over to you, but Grace-Anne, if you've had any experience of that with kids in the classroom, and you've had anything that you found worked, please do chip in as well, please.
Yeah, just get them to do it, get them to sit up nice and straight, do the slow, deep breathing, and distract them a wee bit if you can with whatever, whatever kind of likes or dislikes the child has, just try and, get them to focus away maybe from the breathing a wee bit, even though you want them to do the breathing all right and do the slow, deep breaths. But yes, I mean, one of the things actually that it does happen, and it's not just in children, it happens in adults as well, they tend to panic. And it is a very frightening situation in acute asthma attack. It's like trying to breathe out through a straw. If you get a straw, pinch your nose and put the straw into your mouth and just do breathing through it, that's actually what it's like to breathe through a very narrow airway. Now, I'm not encouraging anybody that has asthma to do that, but people that don't have asthma, if they want to experience it, they can do. But it's, it is very frightening. So just try and distract the child the best you can with the aim of, keeping them doing the deep breathing. And so I guess, Grace-Anne, you have any other kind of wise words in that situation?
Yeah, no, I totally agree. Yeah, keep them calm. And again, for me, managing anything like that, knowledge is power. I feel like if I know what I'm doing, I can manage the situation. So therefore, again, it's only another reason to seek out training like this, because I'm not flailing myself if I've been through it in a training scenario, so I can be there for the child.
I suppose for any child, if they hear the teacher say, now I can see that you're having an asthma attack, and what we're going to do is we're going to follow the 5-step rule, and this is really important. And what we're doing now together is the first step 1, and what we'll do after that is step 2, and just the tone of voice and everything. I suppose even that in and of itself must be reassuring to a child to feel like, oh, it looks like my teacher kind of knows what they're doing, or oh yeah, I know the 5-step rule, we've talked about that, okay, this is what I do next. So I suppose even that puts anybody, Grace-Anne, as well as the teacher themselves, puts the child feeling like they're back in the driving seat or something like that. Anya has said here, what should you not do if somebody's having an attack? I mean, I suppose the first piece, Ruth, which is really important, is not to lie the child down. That's instinctive, because when people do CPR stuff, they assume that lying down is the first step, and it's obviously the opposite. Yes. But are there any other instances that you would say to people, look, this might seem instinctive, but don't do that, please?
Yeah, definitely don't put your arm around them and don't smother them, because your instinct is to go and give them a hug, and, put your arm around their shoulders and that sort of thing. That actually kind of does not help at all, because all you're doing, you can imagine yourself, you're trying to breathe and you have this tight arm around your shoulders. So open any kind of anything around their neck. So if they're buttoned up the neck with their t-shirt or blouse or whatever, open it down a wee bit. But certainly, yeah, they're the main things. Don't lie them down and don't smother them or hug them, which you probably wouldn't be doing anyway in the current climate, but it is instinct, and it's our natural instinct to go and do it.
And then I have 2 queries here about sport. So Deirdre's question, I think, is very pertinent, and we would often hear it not only from teachers but also from coaches, which is, do children need to have their inhalers at sporting events? And I suppose I think that's a really important message, which is, like, it's actually very important for a child with asthma to have their inhaler at a sporting event so that they have it with them in the event of needing it. And also it might be a very routine and important part of their asthma management that they take it in advance of sport. And so when I would speak to Ruth or to Marcus Butler, Dr. Marcus Butler, who's our respiratory clinician, they would say about taking it at least 10 minutes in advance of warm-up of sport, so that the child has the medication, it opens up the airways and it allows them to take their exercise as normal. But I don't know, Ruth, do you have any other question or pieces in terms of sport? Claire has also asked about how to keep a child with asthma safe during sport.
Yeah, the big thing is, yes, if they're doing a designated training session at sport, proper warm-up is really important. Always have their blue inhaler with them, regardless. It doesn't matter whether they're doing sport or not. They should always have a blue inhaler with them, and certainly during sport they should definitely have it. The advice is generally, yes, to take their inhaler before 10 minutes or 20 minutes before sport, and then they shouldn't need it then throughout sport. They may need it maybe towards the end or whenever they're finished, but so yeah, generally it's proper warm-ups is really important, and proper cool downs is really important, that you don't suddenly take into a burst of sport of any kind, or you don't suddenly stop without doing a cool down, because remember that those little muscles are in your airways. Same thing as like any other muscle in the body, in your leg or your arm or anything else. You have to stretch them out and cool them down.
Okay, we have a few questions here about medication. I think probably Grace-Anne has touched on what she learned on the course in terms of being allowed to administer inhalers. Mary has asked, are we allowed to administer inhalers? And I suppose what Grace Ann is saying is that the course said, yes, you are, and that guidance from a teacher means that you can help a child administer their inhaler. But I think, just to back it up again, what we will be trying to do is to say to government, look, teachers need to have absolute clarity about this. We don't need to be debating this point any further. And really what we'd be welcoming is that there's a circular that goes out and that people are aware of this, and that there isn't really any room for debate anymore. Tamara has mentioned that she works in a creche. She said on the first aid course that she did, they were advised not to administer any medication, also inhalers. And is that true? Obviously, that's counter to our experience, Tamara, and counter to what we want to be consistently interpreted as across the board. But I would say what we will do is we will bring this lack of clarity and uneven situation to government's attention, because we think that's really important. And I suppose we are cognizant of the challenges that exist at creche level, because you also need first aid support and training. And obviously there may be children with asthma at that end of the spectrum as well. And then Aoife has asked, Ruth, are there any natural remedies available to prevent a flare-up of asthma?
The short answer to that, I suppose, is no, as such. The way you prevent flare-ups of asthma is taking your controller medication, and that can be an inhaler. There's also a medication called Montelukast that we often use as well as an addition. Again, if there are, certainly with not the, I suppose, the natural side of things, it hasn't been researched enough to show us that it actually is going to help. And you just need to be very careful about what you're doing and what you're giving. If you're thinking about giving some sort of alternative therapy, I would be discussing that with the doctor before you do it. Because there are a number of things that, like, there is the whole concept of butyric breathing for asthma, which again, there is some research out there to show that it is quite beneficial, but again, some doctors don't agree with it, some do. So I will be having that discussion with the doctor before you will be doing it. And likewise, I said the local honey thing there that somebody asked about earlier as well. Again, it is very good for the hay fever type symptoms and that, but again, there isn't enough research around that to tell us that it is actually beneficial for asthma.
And I suppose just to help people understand, I mean, it's set up within the parameters of us as a charity, which is that we are evidence-led in the advice that we give, and our services are led by healthcare professionals like Ruth, who know asthma back and forward to their fingertips. And so for us, when people are asking about questions like that, they may feel that it has helped their child, and there's absolutely nothing wrong with something like that. But we are always saying to do that in conjunction with your healthcare professional, with your GP or your consultant, or with our services, and to never stop your own controlling medication or your own controlling or controller inhaler in the event of you thinking something new works without consulting with a healthcare professional, because that's really important and that's really key to asthma safety and asthma management. We have two questions here that I think are kind of interesting. One of the two I'm not sure is 100% correct, so or clear, so we might try and figure out what it is Nicola's asking. Deirdre has said, should a teacher intervene if the child is in third class and they have their own inhaler? And then she says, should the school have an inhaler in school? So we would say, yes, we'd love for the school to have an inhaler, but you have to go through that 8-hour first aid course to be allowed technically to register for one, to have it without having it on a prescription for a particular child. So that's obviously the administrative challenge that we find with that, right? But I think where Deirdre's saying, should the teacher intervene if a child is in third class? I would say that a teacher should be supporting a child who's in third class as opposed to intervening. But obviously, I suppose the extra piece is if a teacher observes that a child doesn't appear to be doing very well and appears unwell in class, that if they know they have asthma, they may need to say to the child, you know, do you need to take your medication? Because as we know, depending on the child, some kids, absolutely no problem. They take out the inhaler, they'll take it and they'd have no embarrassment about it. Another child might be a little bit shyer, they might be a little bit more self-conscious, and they might need, I suppose, the teacher to give them the A-OK that they're not drawing attention to themselves or they're not making a fuss by taking their medication. So I suppose, Deirdre, I would say there's a bit of judgment with any given child for the, you know, do you suggest it if you think they need it? But in terms of intervention, I think it should be a little bit more about support. Obviously, then there might be some children who actually really explicitly need a lot of help from their teacher on it, you know, depending on the child and how they're doing with their normal life management stuff, you know. But I don't know, Ruth, is there anything there that you want to flag to people?
Sorry, now I'm just looking here, something else that's come in. So a child, like, you know, most kids actually, you know, they probably have asthma for a while, and they're well adapt and well able to use the inhalers themselves. So if a child, say in third class, has to use their medication for whatever reason, let them get on with it. If you feel that they're not actually, and now you know how to use a spacer device, and if you feel they're not actually using it correctly, obviously you can actually help them along the way. But most of them actually are well able to use it themselves and are very adept at using it themselves as well.
And then Nicola has asked, Ruth, for children who have seasonal asthma coughing, will this cause difficulty in the COVID era and classroom? I think the baseline is, maybe what Nicola's asking is, will it be difficult for the teacher to tell if it's normal asthma or seasonal coughing, or will it be COVID? Maybe, but I'm not 100% sure about Nicola's question. I don't know, Ruth, is it clearer to you when you're dealing with the kind of questions you see on the WhatsApp service? Yeah,
look, it's really difficult to kind of differentiate. Is this asthma? Is it a cold? Is it a cough? Is it, or even in hay fever season, is it hay fever? We actually have a lovely chart actually, which I can send to anybody on the WhatsApp. If you send me a message, I can send it to you. And again, like that, you can print it off and have it. So it actually differentiate between COVID, colds, flus, hay fever, and asthma. So there's 5 different things it actually looks at. And it is, like, it's really difficult sometimes to work out which is it. So just to flag, I think Ellen and I were going through the results that we're putting into the annual report for last year, and we shared the image of that graphic, and I think we had something like 40,000 people viewed that graphic. So it's actually a really, really useful piece of kit, and I would suggest if anyone's dialing in that's one of the things that you request from Ruth on the WhatsApp service, because you can save it down to your phone, and it literally has done it out in terms of a table, as in what you should expect to see in cold and flu, what's common in cold, what's common in COVID, what's common with asthma, and it's really handy. So that's certainly one that I would suggest people download. It just really makes it an awful lot more clear. And we have 3 questions in here about asthma and family support that I think are really important, and I think we might wrap it up at that point. If people have asked any questions and we haven't been able to answer them, can I just suggest that you use the WhatsApp service? That's exactly what that's for, and Ruth can share and engage with those. And if any of you have concerns about a child more specifically in your classroom that you don't want to flag in terms of any GDPR or confidentiality issues, you can either use the WhatsApp service and have a chat with either Ruth or Sam on it, or you can give us a call on the Asthma advice line and we'll set up an appointment with the nurse for you to talk that through and to give you some advice. But Fiona has asked how to deal with a child who has asthma noted on their forms but who doesn't have medication in school. So I don't know, Grace Ann, is that something that you had come up against in the school?
Yeah, so if that, I'm guessing that's an intake form. So when you register for the school, or maybe some kind of registration form. So what I would then, I have a template saved, and I would send to a parent, we have on our forms that X child, in our record, sorry, that the X child suffers from, and I leave it blank, and I have it for all different conditions. So asthma, is this something they need to take at school? What do you need from us? And then I would send that to the parents or put it in the school bag. And often it comes back, no thanks, he takes it at home in the morning and we don't need any intervention in school. And then other times the people will say, well, yes, if it's winter, he may need it or something like this. So that's how I would seek out that information. Sometimes you're kind of drawing it on yourself because you could have, I suppose, left well enough alone. And if it was a big enough deal, they would have asked you about it. But I feel like if it's on a form, it must be relevant somewhere. So it's worth getting ahead of it,
Yeah, I mean, I suppose, and we love to facilitate people being as proactive as possible, but anything to do with asthma management. So in our book, having that conversation is really helpful, even if only that it's 1 in 10 children who actually needs that extra little bit of help. At least you're kind of closing the possibility of getting that. And then Jacinta has said, what do you do if you think a parent or guardian is not familiar with asthma management and a child is requesting Ventolin? I guess I suppose on one hand, the first thing I would say is if you think a parent or guardian isn't familiar with asthma and that you think the child may have it, we are always happy for somebody to call us and for them to have a nurse advice line appointment as a first port of call. And if you are concerned as a teacher about how to approach that yourself, you can feel free to send a message, like I said, to the WhatsApp service with Ruth or Sam, or to give us a call yourself if you want maybe to talk through how to have that conversation, because we can give you some of the maybe some approachable language around asthma to say, look, these are some things that might indicate that, you know, a child, it might be worth having a conversation with a GP about it, because it sounds like it's possible the child has asthma. So we can give you some guidance on that. But I suppose the second part of that question is a bit trickier, Ruth, which is that the child is requesting Ventolin. So I don't know if that's something that you'd see commonly, Grace, where the child is asking for it with no reference in prior communications.
No, I wouldn't have come across that. No, where they're asking for it. Again, we have very small children. So it did come up on our training course. So the facilitator was saying that it had been a practice in sports clubs to kind of hand out the blue inhaler to kind of enhance sort of people's ability to participate in sports, which I feel even crazy even saying that out loud, that people could think that was okay, and he was the same. But so maybe it's coming from that, I don't know, but no, certainly not. I wouldn't have had a child request it.
And I don't know, Ruth, have you come across that either?
No, and like I mean, I've years of running asthma clinics in general practice, and I've never come across that situation, to be honest. You know, usually if a child knows, if a child knows that they have to have Ventolin, you will have been told about it, to be honest. I know the parents will have told you. I would hope. No, it's quite an unusual one, to be honest.
Okay, and I'm going to wrap up now shortly, because I know everybody has a cup of tea to be had on a Tuesday evening. There's a question here, and Grace Ann, you may have an input on it, which is advice on how to support children with additional needs and asthma. And I think that is worth touching on. And I'm just going to, while you're answering that, Grace Ann, and you as well, Ruth, because I know Ruth has been really actively involved in Special Olympics for a very long time. It's very close to her heart, so she may have some real expertise in this piece. I'm going to have a quick look at the Q&A on the system to make sure we've answered people's questions. But like I said, please do use either the WhatsApp service this evening or tomorrow to follow up if you have a specific query, or give us a call on the website, and we will send out, like we said, the online pack to each of the people who've dialed in or who've registered for the webinar this evening. And just to say a huge thank you to all of you for joining us. Like, asthma management is what gets us out of bed in the morning, and we are so gratified to see, you know, that this webinar is relevant and is useful and is helpful to you. Do send us any feedback that you want to by email, or like I said, send us an email to nurse@asthma.ie if you want to maybe give us an experience or tell us a little bit of a story about something you've experienced in terms of asthma management in your own life or in terms of the classroom that you think will be useful for us to know about as we are asking for funding for this program. But I'm going to go back here now and have a look in the Q&A just to make sure that we haven't missed any. Ruth, in the meantime, and Grace Ann, do you have advice on supporting children with additional needs and asthma?
Yeah, I guess my experience with children with additional needs and younger adults with additional needs and teenagers in particular through Special Olympics is that they're so clued in. Actually, you know, it actually does surprise me sometimes, you know, how clued in they are about their asthma and about using their inhalers. And I suppose the problems I would foresee with it is that sometimes they're not actually they come into Special Olympics with no spacers, the usual thing. So I do have a lot of education piece to do working with sports clubs in terms of Special Olympics clubs and with service areas and that sort of thing, and with some schools as well, special needs schools. So again, sometimes they can get forgotten about in terms of, you know, good asthma care. But when they're shown how to do something, they will do it down to the letter, as we know. Like, some of them are so good, you know, and you know, if they're told to do something or advised to do something, they will do it. You know, yeah.
Yeah, and just echoing that, we would definitely see that with the children in first and second class, that part of our unit. With the children who are kind of the junior infants level and the preschool, they in some cases are non-verbal, so you need to really be employing those observation skills, you know, and the SNAs I just think are wonderful that work in our unit. They know the children so well, and again, it's empowering those adults to support them and to feel that confidence in using medications, in observing things and noticing those triggers. So that's where I feel it is going to be the main support, is empowering the adults, looking after them for the little ones.
Okay, so just one question that's come through that I think is quite important just for us to clarify. Somebody has asked if they do what they've called a normal first aid course, can they register for the inhaler? The first aid course that we registered people for this program, it's what's called a PHECC first aid course. It's about 8 hours long. it doesn't have to be done through the Asthma Society program. That's a very normal first aid course that is available to teachers to register for. Obviously, normally you have to pay for it, and using the HSE funding for this program, we were able to make that available to 30 schools. But there are a repertoire of about 40 different kinds of first aid course that you do. So it may not have been the PHECC one that you did, in which case, if you've done the PHECC one and you have the cert, you can apply for it. But if you've any debate about that, feel free to email us and we'll come back to you and we'll confirm if we can, once we see the details of the course, whether it's what this legislation requires you to have or not. And I suppose, look, the additional piece we will be saying is, for a child with asthma and for a teacher in the school, we don't believe that somebody actually needs the full 8 hours of training in order to be able to help a child to take the inhaler. And so that's something we will also be feeding back to the Minister and to the department to say, look, is this the most practical way for this to happen, for this administration of an inhaler to happen? We don't think it's about safety, and we think some changes need to happen. And so we will be doing that at a top level. But I noticed that people had 3 or 4 practical questions that they have asked there in the chat function, as opposed to in the Q&A, and apologies on that front. We might have missed a few in the chat function. Will you please send that question on to Ruth on the WhatsApp service on 086 059 0132, and she will answer them directly. And if we think any of them are really of relevance to all of you, we will include 3 or 4 of those Q&A bits when we send on the online pack to all of you in the course of the next week or so. And just to say thank you so much for dialing in. Thanks for your help and support, and always feedback welcome, either, as we mentioned, in terms of any specific kids or experiences, or also in terms of ways we can do this better, one of which would have been us finishing on time. So my apologies on that front. Okay, so thanks everybody for your time, to Ellen and Martina for organising this, to Ruth for her expertise as always. She's absolutely top to toe asthma, and to Grace Ann very generously for giving us her time and her experience and her practical knowledge about how this has worked prior to doing the course, and also prior to doing or after doing the Safe Schools programme. And obviously a big thank you to Trudell Medical, who helped us with some funding to run this programme this year, the Back to School programme. And I'll say good night. Thanks, folks.
Thank you. Thanks.
Bye.
Good night, everyone. Bye.